typical antidepressants, and we classify them based on the mechanism of action into the reuptake inhibitors and the monoamine oxidase inhibitors. Depression is basically characterized by a deficiency of two main neurotransmitters, serotonin and norepinephrine. So we want to basically increase their concentration in the synaptic cleft to ensure that the postsynaptic receptors are basically activated for a longer duration. So there are two main ways of doing that. Either we prevent or inhibit the reuptake of these neurotransmitters back into the presynaptic terminal, where they would otherwise be subsequently degraded via the action of the monoamine oxidase inhibitor. So that is one potential therapeutic objective. The second objective is to simply give a direct monoamine oxidase inhibitor, which would basically inhibit the last degradation step happening within the presynaptic terminal. जो reuptake inhibitors हैं उनको हम डिवाइड करते हैं into selective and non-selective. Selective में we have the one particular drug group कहना चाहिए known as the selective serotonin reuptake inhibitors. और ये जो selective serotonin reuptake inhibitors हैं उनके नाम बहुत important हैं. I'll basically write this down primarily because the names are difficult to follow otherwise. बाकी चीज़ें मैं नहीं लिखूँगी just because I want this to be really quick. ठीक है, so we have fluoxetine. ठीक है, please note the spellings. We have paroxetine. अब थोड़ा different हो गए हैं. Fluvoxamine, citalopram, S-citalopram, S आगे वही spelling है, and sertraline. As the name suggests, ये inhibit करते हैं serotonin के reuptake को. कैसे करते हैं? By inhibiting SERT. What does SERT stand for? It is serotonin reuptake transporter. ठीक है, SERT, serotonergic transporter. To be honest, we don't really care what it stands for. बस याद कर लें कि it is SERT which gets inhibited. Anyways, in spite of what I said, I just checked. It stands for serotonin reuptake transporter, just because the pharma department does ask the weirdest stuff. Serotonin reuptake transporter, which is normally located on the presynaptic terminal and which is responsible for the reuptake of serotonin which was released in the presynaptic terminal. So when we give the SSRIs, for example fluoxetine or paroxetine or maybe fluvoxamine, these drugs primarily inhibit the SERT which is located on the presynaptic terminal, meaning the concentration actually increases in the synaptic cleft and activation of the receptor continues for a longer duration. So how does SERT normally work? Serotonin basically binds on the extracellular side along with sodium and chloride, and there's a conformational change which basically shuffles the serotonin to the other side, and when potassium binds to the other side from the intracellular side, the serotonin is released and the SERT is basically able to return to its original conformation and therefore bind with another serotonin which is present on the extracellular side. So this is the mechanism of action. So although these are antidepressants, they have plenty of other indications, including for the long-term treatment of generalized anxiety disorders and panic disorders and PTSD. For the acute conditions, for the acute anxiety, we prefer the benzodiazepines, but for the long-term treatment, the antidepressants are a better option for a number of reasons, primarily because they are not associated with dependence, unlike the benzodiazepines. Secondarily, we also use the antidepressants for other indications such as certain eating disorders, bulimia, not anorexia, as well as for OCD, which is obsessive compulsive disorder. ठीक है? These are some of the indications which we have to keep in mind. The thing to remember is that whenever we are attempting to treat OCD, we do so using an antidepressant which has a primary effect on serotonin. Therefore, SSRIs are actually quite preferred for the treatment of OCDs, and another drug from the antidepressants, clomipramine, which is basically a TCA, is also specifically preferred for this particular indication. As for the treatment of bulimia, which as previously stated is an eating disorder, we have an FDA approved drug from the SSRI class, and the name is fluoxetine. A good way to do this topic is to just write down the important parts. Okay, so it's actually approved, FDA approved. ठीक है, और in general SSRIs के साथ we have to write OCD की treatment में भी. All right. Um, so basically, moving onwards. So we've talked about the mechanism of action. We've talked about the drugs. Let's talk about certain interactions and certain side effects. Fluoxetine and paroxetine, the first two, are CYP2D6 inhibitors. Therefore, if you were to give them with a tricyclic antidepressant, which is also an antidepressant, the levels of the TCA can increase to toxic levels because TCA is primarily metabolized by CYP2D6, which is getting inhibited by these two SSRIs. So, this is a potential drug interaction waiting to happen and can be fatal because TCA toxicity can lead to seizures because of its seizure threshold action as well as very fatal arrhythmias, and also certain anticholinergic effects. Similarly, fluvoxamine over here is known to inhibit CYP3A4. So you're not supposed to give fluvoxamine with certain drugs like diltiazem because diltiazem is basically metabolized by CYP3A4 system. The side effects are very important and they all have to do with increased serotonin tone. So starting with the serotonin tone which is seen in the chemoreceptor trigger zone. Chemoreceptor trigger zone may we have five serotonin 3 receptors basically, and because of the agonist role at the chemoreceptor trigger zone, nausea and vomiting is by far one of the most common actions and most common side effects of the SSRIs, but fortunately they tend to be self-limiting. Now the agonist action is also at the level of the brain and also at the level of the spinal cord at the same receptors. So a very common side effect is actually diminishment in both sexual function as well as sexual interest. So there is both a loss of libido, a loss of sexual arousal, as well as impairment and premature ejaculation. Not premature, sorry. Impaired ejaculation is a side effect of the SSRIs, and because of this effect, an off-label use of the SSRIs is for the treatment of premature ejaculation. Bear in mind, this is an off-label use. Off-label use for, what is the off-label use for? It is for premature ejaculation. So we've talked about certain very important side effects: nausea, the vomiting, the loss of libido. Withdrawal syndrome is quite common, and it is most, how shall I say, it is most potent with fluvoxamine, which has the shortest duration of action, and it is least potent with fluoxetine. क्योंकि fluoxetine उसकी अपनी तो half life इतनी अच्छी नहीं है, but it is metabolized to its end product, its metabolic end product, norfluoxetine. And ये जो norfluoxetine है, it is actually an active metabolite with a half life of 180 hours, so approximately 7 days. जितनी हाफ लाइफ ज़्यादा होती है किसी भी ड्रग की, उसकी इन जनरल विड्रॉल की टेंडेंसी उतनी ही कम होती है. So withdrawal syndrome is actually super important. I'll just basically write it down over here. This is super important. So we've talked about the nausea, the diminished sexual function. We've talked about discontinuation syndrome. Weight gain is also associated, and this weight gain is actually mostly seen with paroxetine. Paroxetine में बहुत ज़्यादा weight gain होता है. Most of the SSRIs are category C drugs, meaning they are not outright teratogenic, but they do have certain unpleasant effects on growth restriction of the fetus, etc. We have one exception, which is paroxetine, which is a category D drug because it is teratogenic and it is actually associated with cardiac septal defects. And because we're doing CNS pharmacology, when you talked about the drugs used in Parkinsonism, we talked about the dopamine analogs and we talked about the ergot alkaloids, which included bromocriptine and pergolide, and they were basically short acting and they were associated with vasospasm. But we also talked about the newer ones, which were non-ergot alkaloids, specifically pramipexole and propinerol. And the fact of the matter was that these were safer drugs because they were longer acting, they were not associated with gangrene, but they did have certain other implications, including their use as in restless leg syndrome as well as the side effects of mood disorder. And mostly lack of impulse control. So one thing we studied when we were talking about the ergot alkaloids, when we talked about pergolide, was the fact that it can cause cardiac valvular defects. So you're not supposed to give it to someone who is pregnant. Similarly, जो paroxetine है ना, which also starts with P, is linked with cardiac septal defects, not valvular defects. So ये बात important है. So now let's talk about the reuptake inhibitors which are non-selective. अभी हमने selective की बात की है ना, जिसमें SSRIs थे. Non-selective में we have two, the SNRIs and the TCAs. SNRIs की बात करते हैं, वो inhibit करते हैं norepinephrine, serotonin दोनों की reuptake को via action on the SERT as well as action on the NET. ठीक है, SNRI का एक्शन कहाँ पर हो रहा है? नेट पर भी हो रहा है. एंड सेकेंडरीली द एक्शन इज ऑल्सो सीन ऑन द सर्ट as expected. Alright, now we need to know the names. We start with duloxetine, venlafaxine. Venlafaxine also has its metabolite which is active, which is desvenlafaxine. And the names are a bit hard, but nothing you won't be able to get a hang of. नोटिस कि ये डिफरेंटली एंड करते हैं. duloxetine है, जबकि venlafaxine है, और desvenlafaxine है. So it's teen and exene basically. So we also have milnacipran, ठीक है, milnacipran and levomilnacipran, ठीक है. अच्छा, इनमें इंटरेस्टिंग पॉइंट्स क्या हैं? जो हमारे पास venlafaxine है ना, it is supposed to have the lowest protein binding which can be effective and which can be quite helpful in certain cases. जबकि जो duloxetine है उसकी बहुत हाई प्रोटीन बाइंडिंग है. फर्स्ट थिंग. दूसरी बात है कि ज़्यादातर जो SNRIs हैं, जो SSRIs हैं, pretty much all the antidepressants, they're undergoing extensive hepatic oxidative metabolism. But in this regard, venlafaxine एक हम कह सकते हैं it's a exception because इसकी oxidative metabolism नहीं होती, इसकी सिर्फ हम कह सकते हैं conjugation होती है. So it's comparatively safer in someone who has hepatic impairment. जबकि duloxetine की significant hepatic oxidative metabolism होती है and therefore dosage adjustment is indicated in someone who has hepatic impairment. Secondarily, rarely but definitely duloxetine can be hepatotoxic. ठीक है. So talking about, we've talked about the fact कि हम antidepressants के तौर पर भी SNRIs को इस्तेमाल कर सकते हैं as well as for certain indications like GAD. ठीक है. अब प्राइमरीली जब हम SNRIs की अदर इंडिकेशंस है ना, अदर देन डिप्रेशन, इंक्लूड वेरी प्रोमिनेंटली, एक तो हमने क्रॉनिक पेन कंडीशंस में डेफिनेटली देना है. SNRIs का एक्शन ना नॉरपेनेफ्रिन पर भी है. फर्स्ट थिंग टू अंडरस्टैंड. ठीक है. सो वी आर गोइंग, माई अपॉलॉजीज, आई जस्ट रिपीटेड कि ये नाम है duloxetine, venlafaxine, milnacipran, levomilnacipran. And the important thing to note other than the names is the fact that duloxetine is the one which can in certain cases be hepatotoxic, whereas desvenlafaxine and venlafaxine is the one जो कि आप hepatic impairment में भी दे सकते हैं without dosage adjustment because इसका metabolism काफ़ी different है. So the indication, so we've generally talked about the fact कि हम antidepressants को eating disorders में भी दे रहे हैं as well as for indications like OCD and GAD. लेकिन जो स्पेसिफिक एडिशनल हमारे पास इंडिकेशन है ना फॉर द SNRIs एंड ऑल्सो द TCAs, बिकॉज बोथ ऑफ देम आर एक्चुअली हैविंग एन इफेक्ट on norepinephrine too. So they are also additionally used for the treatment of various chronic pain conditions. Okay? And for this particular indication, duloxetine is actually FDA approved for the treatment of chronic joint and muscle conditions. Okay? Whereas milnacipran is used for the treatment of a condition known as fibromyalgia, वो basically एक idiopathic condition है जिसमें muscle aches होते हैं लेकिन cause नहीं पता होती है. So you have to remember these 2 points. Additionally, duloxetine urinary stress incontinence की treatment और management में भी इस्तेमाल किया जाता है. So when we are going to write about the side effects, so first of all we're just going to have to rewrite the side effects which we saw with the SSRIs because these are also increasing the serotonergic tone. But additionally, we have to add some extra side effects which have to do with the norepinephrine, primarily increased BP, increased heart rate. Dose-dependent hypertension is seen with the immediate release forms of venlafaxine. ठीक है. Secondarily, among the SSRIs and among the SNRIs, venlafaxine is the one which is associated with the most cardiotoxicity on overdose. ठीक है. Among SSRIs and SNRIs, ठीक है. We haven't considered TCAs when saying this. Alright. So venlafaxine associated है with dose dependent hypertension and cardiotoxicity. ठीक है. Additionally, we've stated that duloxetine is potentially hepatotoxic. Now we need to talk about the TCS. TCS भी primarily reuptake inhibitors ही हैं, and ये primarily serotonin and norepinephrine की reuptake को ही inhibit कर रहे हैं, but they are much less selective. They're also going to have an effect on blocking the histamine 1 receptors. The muscarinic receptors are also going to get blocked, and quite strongly at that. And they're also going to block the alpha 1 receptors, but this blockage will be significantly less potent compared to the blockage of the muscarinic receptors. Therefore, we can expect the symptomatology of side effects including sedation because of the histamine, loss of accommodation, blurry vision, constipation, etc. because of the anti-muscarinic side effects, as well as occasionally orthostatic hypotension. The thing to understand is कि हम TCS को divide करते हैं into tertiary and secondary based on their structure. Tertiary में we include imipramine. I'll just write down the names. अभी tertiary के लिख रही हूँ. Imipramine, and we have something called amitriptyline, ठीक है? And these are the ones which are associated with maximal antimuscarinic effects. We also have certain secondary TCAs, including the interestingly named desipramine as well as nortriptyline, but these are not associated with as much antimuscarinic side effects. So there's a couple of reasons that even though we can use both the TCAs and the SNRIs for conditions associated with neuropathic pain, over time we have begun to prefer the SNRIs for this indication because they're associated with significantly less side effects. Because ये वाली जो side effect profile है ना, orthostatic hypotension and antimuscarinic वाली, that is not seen with the SNRIs, ठीक है? Alright, so we have the monoamine oxidase inhibitors, जिसमें we have the selective and the non-selective, ठीक है? Non-selective A और B दोनों को inhibit कर रहे हैं. One thing I actually kind of forgot is the concept of the serotonin syndrome, which can happen with both the SSRIs and the SNRIs if they're used together with the monoamine oxidase inhibitor within the time period of 2 weeks. ठीक है, यानी 2 weeks पहले discontinue किया monoamine oxidase inhibitors को और start कर लिया either SSRI या SNRI या even sometimes certain opioids पे, क्योंकि serotonin बहुत ज़्यादा हो जाती है. There are a couple of reasons why serotonin is accumulating, and too much serotonin can lead to bad stuff happening, both having to do with cognitive impairment as well as certain ANS related side effects. Back to the monoamine oxidase inhibitors. Non-selective monoamine oxidase A and B दोनों को inhibit करते हैं, and we need to know the name. Non-selective phenelzine है. We also have something called tranylcypromine. ठीक है, जो selective है ना, उसमें जो specifically monoamine oxidase A को inhibit कर रहा है ना, that is known as moclobamide. ठीक है, and we don't really care about MAOAB right now because those are used for anti-Parkinson usage, treatment, whatever you want to call it. So yeah, talking about the side effects, actually monoamine A is located in the GIT, और वो normally जो tyramine होता है ना food को उसको degrade करता है. So if you give a non-selective inhibitor such as monoamine oxidase A and B inhibitor like tranylcypromine, and in addition to the antidepressant therapeutic utility, you've also inhibited the MAOA located in the gut, and then you take, for example, at the same time you take cheese, which contains the amino acid tyramine, which normally would have gotten degraded in the gut, but in this scenario it gets reabsorbed. And when it gets reabsorbed, tyramine can lead to a hypertensive crisis, which is generally treated with phentolamine. So all of this is rather super important. So इसको हम कहते हैं cheese reaction, which is why you shouldn't be taking a non-selective monoamine inhibitor with a food substance which contains tyramine. These side effects are not seen with the comparatively selective inhibitors. Similarly, serotonin syndrome, as previously stated, अगर आपने for example MAOA inhibitor इस्तेमाल किया है तो कम से कम आपने 2 हफ्ते का गैप रखना है before starting an SSRI and an SNRI, because it takes approximately 2 weeks for the monoamine oxidase enzymes to get regenerated. Similarly, अगर आप SSRI इस्तेमाल कर रहे हैं तो you have to wait for its half life to be over before starting the monoamine oxidase inhibitor. नॉर्मली 2 हफ्ते होते हैं, लेकिन फ्लॉक्सिटीन के केस में 4 हफ्ते का गैप देना होता है बिकॉज उसकी हाफ लाइफ होती है बहुत ज़्यादा. सो यू हैव टू वेट बिफोर यू आर श्योर कि इट इज़ कम्प्लीटली आउटसाइड ऑफ द बॉडी. ठीक है. सो सेरोटोनिन सिंड्रोम चीज़ रिएक्शन दोनों इंपॉर्टेंट है. एंड इसके अलावा सर्टन हमारे पास एटिपिकल्स हैं इंक्लूडिंग मिटाज़ेपीन. मिटाज़ेपीन ना एक्चुअली 5 सेरोटोनिन 1A एंटागनिस्ट भी है और अल्फा 2 एंटागनिस्ट भी है, और इन दोनों एक्चुअली प्री साइनेप्टिक रिसेप्टर्स के एंटागनिज्म से जो रिस्पेक्टिव न्यूरोट्रांसमीटर है उनके लेवल बढ़ते हैं. सो दैट्स अ बिट ऑफ एन इंटरेस्टिंग थिंग टू कीप इन माइंड. Similarly, we have another antidepressant, bupropion, जो कि in addition to increasing the levels of serotonin and norepinephrine also increases dopamine levels. So it's actually used for cessation of smoking. So these are important.